Greetings dear viewers. In this video, I would like to explain about the measles virus's general characters, its transmission method, structure of the virus, pathogenicity, clinical syndromes, and treatment for this viral infection. I am Dr. M. Manigandan, Assistant Professor from the Department of Microbiology, Sacred Heart College, Tirupattur. Introduction. The measles virus comes under the Paramyxoviridae family with 5 genera and its viral particles. At first, morbillivirus, which includes the measles virus. Secondly, paramyxoviruses, which includes the parainfluenza and mumps viruses. At last, pneumoviruses genera, which include the respiratory syncytial viruses. A new group of highly pathogenic paramyxoviruses, including two zoonosis-causing viruses, that is Nipah and Hendra was identified in 1998. Infections of the viruses that comes under Paramyxoviridae family. At first, the measles virus, which is an acute, highly infectious disease causing virus characterized by fever, respiratory syndrome, and maculopapular rash, that is rubiola. And secondly, parainfluenza viruses, which causes upper and lower respiratory tract infections, especially in children, including pharyngitis, croup, bronchitis, bronchiolitis, and pneumonia. The another virus is the mumps virus, which causes parotitis. The RSV virus, which causes mild upper respiratory tract infections in children and also in adults, but can cause life-threatening pneumonia in infants. Infections of measles virus, which is also known as rubiola, which causes 3 C's, that is cough, coryza, or conjunctivitis, and sometimes it may also cause Koplik spots. The measles infection along with the rubella, roseola, fifth disease and chickenpox are 5 common childhood infections. Every year, 45 million cases were observed with this measles infection. The infections are majorly observed in younger age, less than 20 years, which had experienced this rash, high fever, cough, conjunctivitis, and coryza of measles. Measles is highly contagious and is transmitted from person to person by respiratory droplets. Structure. The paramyxoviruses are relatively large viruses comparatively has the similar structure and which are all roughly spherical with size of 120 to 250 nanometer in diameter. Often they are pleomorphic in nature. The central core consists of a negative sense single-stranded RNA and the envelope consists of spikes with the hemagglutinin protein alone and there is no neuraminidase found. The other proteins includes nucleoprotein, polymerase phosphoprotein and large L proteins are observed in this viral family. Transmission. The mode of transmission of measles virus occurs by direct contact with the respiratory secretion and aerosols created by coughing and sneezing. The virus enters the body through the respiratory tract and conjunctiva. Hematogenous and transplacental transmission can occur when measles occurs during pregnancy. Pathogenesis. Humans are the only natural host for measles virus, although numerous other species, including monkeys, dogs, and mice, can be experimentally infected. The virus gains access to the human body via the respiratory tract where it multiplies locally. The infection then spreads to the regional lymphoidal tissues where further multiplication occurs. Primary viremia disseminates the virus, which then replicates in the reticuloendothelial system. Finally, a secondary viremia seeds the epithelial surface of the body, including the skin, respiratory tract, and conjunctiva, where local replication occurs. The described events occurs during the IP, which typically lasts 8 to 12 days but may last up to 3 weeks in adults. During the prodromal phase, that is from 2 to 4 days, and the first 2 to 5 days of rashes, virus is present in tears, nasal, and throat secretions, urine, and blood of the infected individual. The characteristic maculopapular rash appears about day 14, just as circulating antibodies become detectable and the viremia disappears and the fever falls. The rash develops as a result of interactions of immune T cells with the virus infected cells in the small blood vessels and lasts for about 1 week. Involvement of central nervous system is common in measles. Progressive measles inclusion body encephalitis may develop in patients with defective cell-mediated immunity. A rare late complication of measles is subacute sclerosing panencephalitis, that is SSPE, a fatal disease that develops years after the initial measles infection and is caused by virus that remains in the body after acute measles infection. Clinical symptoms. Measles is a highly contagious febrile illness. After an incubation period of 8 to 12 days, measles is typically a 7 to 11 days illness with a prodromal phase of 2 to 4 days followed by an eruptive phase of 5 to 8 days. The first phase, prodromal phase of measles, which is characterized by fever and the three C's, coryza of nose, conjunctivitis usually associated with photophobia, and cough. Koplik spots and lymphopenia were also being observed. The cough and coryza reflects an intense inflammatory reaction involving the mucosa of the respiratory tract. Koplik spots are small, bluish white ulcerations of the buccal mucosa. The fever and cough persist until the rash appears and then subside within 1 to 2 days. The rash starts on the head and spread progressively to the chest, the trunk, and down the limbs, which appears as light pink, discrete maculopapular that coalesce to form blotches and becomes brownish in 5 to 10 days. The fading rash resolves with desquamation. The second condition and clinical symptom is the modified measles, which occurs in partially immune persons such as infants with residual maternal antibody. The IP is prolonged, prodromal symptoms are diminished. Koplik spots are usually absent and rash is mild. The third condition is the atypical measles. Atypical measles occurs in individuals who receive the older inactivated vaccine and later exposed to a wild strain. It may also rarely occurs in person vaccinated with attenuated vaccine. It is characterized by a prolonged high fever, pneumonitis, and the rash. The rash characteristically begins peripherally and may be urticarial, macular, papular, hemorrhagic, or vesicular. The most common complications of measles is otitis media, occurring in 5 to 9% of cases. Pneumonia is a life-threatening complication of measles caused by secondary bacterial infections. Giant cell pneumonia is serious complication in children and adults with a deficiency in cell-mediated immunity. Complications involving central nervous system are the most serious. Acute encephalitis occurs in about 1 is to 1000 cases. Post-infectious encephalomyelitis is an autoimmune disease associated with an immune response to myelin-based protein. The mortality in encephalitis associated with measles is about 10 to 20%. The majority of survivors have neurologic sequelae. Subacute sclerosing panencephalitis (SSPE) is a rare late complications of measles, occurs with an incidence of about 1 is to 3 lakh cases. It is a degenerative disease of the central nervous system caused by persistent measles infection. The disease begins 5 to 15 years after a case of measles. It is characterized by progressive mental deterioration, involuntary movements, muscle rigidity, and coma. The condition is associated with the presence of an extremely high measles antibody titers in the blood and CSF. Other complications of measles include bronchopneumonia, laryngotracheal bronchitis, that is croup, and diarrhea. Measles, measles includes labor in some pregnant women, resulting in spontaneous abortion or premature delivery. The virus may cross the placenta and infect the fetus during maternal measles. Laboratory diagnosis. Laboratory diagnosis is necessary in cases of modified or atypical measles. The specimen to be collected or a respiratory specimen, conjunctival specimen, urine, blood, and brain tissues. Specimens are collected during the prodromal stage and the period following until 2 days after the appearance of rash. First test is the microscopy, the demonstration of multinucleated giant cells measuring up to 100 nanometer in diameter in GEMSA stained smears is diagnostic of measles. Immunofluorescence study of exfoliated respiratory cells in nasopharyngeal secretion viral particles. Third one is the antigen detection. Measles antigens can be detected directly in epithelial cells, in respiratory secretions, urinary sediments, pharyngeal secretions, and by direct immunofluorescence antibody test. Fourth one is the isolation and identification of virus. Nasopharyngeal and conjunctive swabs, blood samples, respiratory secretions, and urine collected from infected individual during febrile period or appropriate source of viral isolation. Growth can be obtained in primary human or monkey kidney cells. Growth occurs slowly with the cytopathic effect containing both intranuclear and intracytoplasmic inclusion bodies in 7 to 10 days. Serological tests, which is a confirmation of measles, depends on a fourfold rise in antibody titer between acute phase and convalescent phase. Demonstration of measles specific antibody in a single specimen drawn between 1 to 2 weeks after the onset of rashes will help in serological demonstration. The major methods applied are ELISA, hemagglutinin inhibition assay, neuraminidase test. Treatment and prevention of measles infection. Ribavirin, either intravenous or in aerosol form, is evaluated nowadays to treat severely affected adults and immunocompromised individuals with acute measles or subacute sclerosing panencephalitis. However, the drug is yet to be used for regular treatment of cases of measles. Vitamin A treatment in developing countries has reduced the mortality and morbidity. Active immunization with a highly effective and safe attenuated live measles viral vaccine is available. If it now uses squads and Moraton attenuated strain of the original Edmond strand B strain. The vaccine is available in monovalent form in combination with live attenuated rubella vaccine and live attenuated rubella and mumps measles vaccine, that is MMR, currently used for universal immunization of children. The efficacy rate of this measles viral vaccine is around 90 percentage. 90 to 98 percentage. Duration of immunity is lifelong, but the dosage are scheduled between two. One is initial and second is the booster dose. First at the age of 9 months and the second booster dose at the age of 2 years. We may also involve or use passive immunization, that is with the pooled sera containing antibody against measles virus, confers passive immunity to infants and susceptible contacts of measles cases. Thank you for your patient listening. Kindly encourage us by your subscription and support us in our comment section. Thank you.